Thank you for joining us today on the Anesthesia and Perioperative Medicine channel.
Willkommen auf dem Kanal für Anästhesie und perioperative Medizin.
Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria.
आज एनेस्थीसिया और पेरीऑपरेटिव मेडिसिन चैनल पर हमारे साथ जुड़ने के लिए धन्यवाद।
Welcome, everyone. Today, we're diving deep into one of the most complex and high-stakes scenarios we face, the acute surgical abdomen in a pregnant patient. You've got 2 lives in your hands, and the clock is ticking. In this explainer, we're going to walk through the entire journey. We'll start with the diagnostic maze of the acute abdomen, then get into the core physiological principles that form our playbook. After that, we'll cover the practical anesthetic techniques before exploring 2 really harrowing real-world cases that push these principles to the absolute limit. And finally, we'll boil it all down to the key takeaways you can use in your own practice. So let's start with challenge number 1, just figuring out what's going on.
Our journey really has to begin here, with what is often the biggest hurdle of all, getting the diagnosis right. The acute abdomen during pregnancy is, well, it's a master of disguise. It's a clinical situation where all the usual signs and signals that we depend on can become blurry, misleading, or just plain absent. I think this quote just nails it. It perfectly captures the challenge we're up against. You see, the normal physiological changes of pregnancy create this constantly moving clinical landscape. The ground beneath your feet is literally shifting. All the diagnostic rules change, and a signpost that would be crystal clear in any other patient suddenly becomes ambiguous. It forces us to operate with an incredibly high index of suspicion.
So what makes it so tough? Well, this slide shows the heart of the problem, using the most common surgical emergency in pregnancy as an example: appendicitis. Look at the classic symptoms on the left: loss of appetite, vomiting, some vague belly pain. Now look at the right. That looks an awful lot like a normal Tuesday in the first trimester, doesn't it? Morning sickness, weird food cravings, the general discomfort from a growing uterus. The overlap is huge. This means our first line of defense, a clear clinical picture, is gone. To make it even worse, our labs can fool us too. Pregnancy itself causes a rise in white blood cell count, a physiological leukocytosis, which can either mask a real infection or make us think there's one when there isn't. And if the symptoms weren't tricky enough, the anatomy itself is working against us. Again, the appendix is the perfect example. As you can see here, as the uterus grows, it shoves everything else out of the way. The appendix gets pushed up and out, superiorly and laterally. By the time the patient is at term, that appendix could be way up in the right upper quadrant, or even in the flank. Now, this anatomical shift causes 2 huge clinical problems. First, the pain is in the wrong place. The patient might complain of flank pain, making you think of a kidney infection, or RUQ pain, making you think of gallstones. Second, and this is the real kicker for our physical exam, the inflamed appendix gets pushed away from the abdominal wall, away from the parietal peritoneum. This means those classic signs we rely on, like rebound tenderness and guarding, can be diminished or completely absent. It can make a raging surgical abdomen feel deceptively mild. And all of this leads to diagnostic delay, which is why the risk of perforation is highest in the 3rd trimester, exactly when the diagnosis is hardest to make.
And this just puts it all into perspective, right? The diagnostic net we have to cast is enormous. The cause of that abdominal pain could span 4 different specialties. Is it obstetric, like an abruption? Is it surgical, like we've been discussing? Could it be gynecologic, like a twisted ovarian cyst? Or could it be a medical curveball, like pneumonia presenting with referred abdominal pain? There is a handy little clinical tool called the Alders sign. You have the patient lie on her left side. If the point of maximal tenderness moves with the uterus, it's more likely an obstetric issue. If it stays put, it's more likely something else, maybe surgical. But at the end of the day, given the stakes, any delay can be catastrophic for both mom and baby. Okay, so the surgical team has made the call. It's time to go to the OR. Now the focus shifts to us, and this section is our playbook. Understanding the profound, systemic, physiological changes of pregnancy isn't just academic. It is the absolute bedrock of providing safe anesthesia. Let's really break this down, because every single one of these lines changes our game plan. Cardiovascular. Cardiac output is up by almost 50%, but all that volume means nothing if it can't get back to the heart. After 18 weeks, that gravid uterus lying flat on the back can crush the vena cavas, dropping cardiac output to 0. That's why left uterine displacement isn't just a good idea, it's mandatory. Respiratory. Oxygen consumption is way up, but the lungs' oxygen reserve, the FRC, is way down. What does that mean for us? It means during induction, when the patient is apneic, she will desaturate with terrifying speed. Meticulous, thorough pre-oxygenation is absolutely critical.
Gastrointestinal. Progesterone relaxes smooth muscle everywhere, including the lower esophageal sphincter, and gastric emptying slows to a crawl. The take-home message is simple. Every pregnant patient past the first trimester is a full stomach, period. Aspiration is a huge risk. And finally, the CNS. Progesterone and endorphins make the brain and nerves more sensitive to our drugs. MAC is down by as much as a third, and they're more sensitive to our spinals and epidurals. We have to cut our doses, or we risk toxicity and going too deep. This analogy is just perfect for framing our dual mission. Our first job is to fly the plane. That's ensuring maternal safety. We have to manage all those physiological changes to prevent hypotension, hypoxia, and aspiration. But at the same time, we have a second job, protecting our very precious passenger, the fetus. And that really boils down to two key things. First, we avoid drugs that could be teratogenic, especially during that critical first trimester. And second, and this is the big one, we do everything in our power to prevent fetal asphyxia. A baby's oxygen supply depends entirely on blood flow through the placenta. So anything that compromises maternal perfusion, whether it's hypotension from aortocaval compression, hypoxia from a tough airway, or acidosis from sepsis, directly threatens the fetus.
All right, that's the why. That's the physiology. Now let's get into the how. How do we take all this knowledge and apply it to our actual techniques and choices in the operating room? So, one of the first big questions is always regional versus general anesthesia. Now, regional is often seen as the ideal choice, and for good reason. The mother stays awake, we minimize the baby's drug exposure, and it sets us up perfectly for great post-op pain control. But let's be realistic. In a true crashing emergency, or if the patient is uncooperative or has a contraindication, general anesthesia is the way to go. It gives us definitive airway control, and a nice side benefit is that our volatile agents can help relax the uterus and potentially stave off preterm labor. But here's the most important thing on this slide. When both techniques are managed well, meaning we are aggressive about preventing hypotension and hypoxemia, the data shows that fetal outcomes are pretty much the same. The best technique is the one that's done expertly and safely. Now, if we do choose general anesthesia, a rapid sequence induction is not optional. It is our mandatory safety protocol. Let's walk through these critical steps. 1. We already talked about this, pre-oxygenate like unit for at least 3 full minutes to fill up those depleted oxygen stores. 2. Prophylaxis against aspiration with something like sodium citrate. 3. Cricoid pressure. 4. A fast-acting induction agent and succinylcholine for paralysis. 5. Intubate with a smaller tube than you might normally reach for, something like a 6.0 or 6.5, because pregnancy hormones make the airways swollen and friable. And finally, step 6 is absolutely crucial. Confirm that tube is in the right place with end-tidal CO2 before you let go of cricoid pressure. This entire sequence is vital to keeping the mother safe. Choosing our drugs is another key part of the puzzle. This table is a really practical guide. Now, while no anesthetic agent has been definitively proven to be teratogenic in humans at the doses we use, we definitely have our favorites, drugs with a long track record of safety. You can see that many of our go-to drugs, propofol, Sevo, fentanyl, our common local anesthetics are category B, which is very reassuring. Others, like thiopental or ketamine, are category C. The really important thing is to steer clear of anything in category D, like diazepam, where there's evidence of fetal risk. This framework helps us make smart, defensible decisions to keep the fetus as safe as possible. Okay, theory is one thing. Now let's see how these principles hold up in a real-world, absolute nightmare scenario. This first case is a 26-year-old woman, first pregnancy, 30 weeks along, who shows up with a rare and catastrophic bleed. So the patient arrives, and she is in extremis. Just look at these numbers. She is in profound hemorrhagic shock. Her blood pressure is in the tank, her heart is racing to keep up, and she's confused. Her hemoglobin is already down to 8.5. And then the most tragic finding of all, no fetal heart sounds. Right there, in that moment, the entire clinical focus shifts. As much as we always want to save 2 lives, this case has now become singularly about maternal survival. The picture is clear. Acute abdomen with total hemodynamic collapse. She needs to go to the operating room now. So she's rushed to the OR for an emergency laparotomy. The surgeons open her up, and what they find is just staggering. These pictures show a massive, dark, angry-looking hematoma that's just consuming the entire retroperitoneal space, plus a huge amount of free blood in the abdomen. The surgeons are searching everywhere for the source. Is it a ruptured aneurysm, a torn liver, a uterine rupture? But there's nothing. The bleeding is diffuse, and its origin is a complete mystery. After they deliver the deceased fetus, another problem emerges. The uterus just won't contract. It's completely atonic. Likely from the profound shock and the massive amount of fluids and blood she's receiving, it becomes yet another source of bleeding.
You can see here the surgeons have thrown a B-Lynch suture. This is basically a way to physically squish the uterus with sutures to get it to stop bleeding. It's a classic obstetric move for postpartum hemorrhage, but here it's happening on top of this other massive unidentified bleed. So, after a massive transfusion, taking out her spleen, and temporarily packing the retroperitoneum, they're finally able to stabilize her and get her to the ICU. This CT scan from after the surgery shows that huge hematoma is starting to regress. But the incredible thing is, even after all that, no specific cause was ever found. This was a case of idiopathic spontaneous hemoperitoneum, a diagnosis of exclusion that is incredibly rare, and a terrifying reminder of how quickly things can go wrong. So if that first case was a trial by fire from hemorrhage, this second case is a trial by sepsis. This is the story of a 29-year-old woman at 34 weeks, and her hospital course is just a cascade of one devastating complication after another. It truly pushes the boundaries of what's possible in critical care. This timeline really tells the whole story. It starts out pretty innocently. She's admitted for mild pancreatitis. But on day 3, the bottom completely falls out. She needs an emergent C-section for fetal distress, but she rests right after induction. They get her back, but the baby doesn't make it. The very next day, she crashes into septic shock. She goes back to the OR for a damage control laparotomy, but she's so unstable and swollen they can't even find the source. It takes another surgery 2 days later to finally identify the culprit, a spontaneous hole in her jejunum. They control the source, but her abdomen is so inflamed there's no way to close it. For the next several weeks, she's managed with an open abdomen, using advanced systems to slowly bring things back together, until finally, on day 27, they can close the fascia.
This image shows you the stark reality of that decision. This is what an open abdomen in severe sepsis looks like. The bowels are incredibly swollen and just covered in septic fluid. If you tried to force that closed, you'd cause abdominal compartment syndrome, cutting off blood flow to her organs and making it impossible to ventilate her. The only safe move is to leave it open, put on a temporary dressing, and buy time for that inflammation to go down.
And here you can see both the problem and the solution. On the left, that's the source of all the chaos, that spontaneous perforation in her small bowel. And on the right, you see the amazing technology that helps save her. This is a combination of negative pressure therapy, basically a wound vac for the abdomen, to suck out all that septic fluid, along with an ABRA system. Those little anchors apply constant, gentle tension to slowly pull the abdominal wall back to the midline over days and weeks. It's this combined approach that was absolutely critical to her survival.
You know, these two cases are about as extreme as it gets, but they do a fantastic job of reinforcing the core principles we need to remember. So let's boil everything we've talked about down into the most critical, actionable lessons. So if you remember nothing else, remember these points. First, always maintain a high index of suspicion. Atypical presentations are the rule, not the exception. Second, left uterine displacement. It is not optional. It is a life-saving maneuver. Do it every time. Third, every pregnant patient is a full stomach. A slick, well-executed RSI is your best friend for securing the airway safely. Fourth, our primary goals are always maternal safety first, because a stable mother is the only way to maintain perfusion to the placenta and fetus. And finally, as that second case showed us, in the absolute worst-case scenario of sepsis and an open abdomen, things like negative pressure therapy can be an incredible bridge to get the patient stable enough for definitive surgery.
And we end with this question because it really gets to the very heart of what we do. 99% of the time, what's good for the mother is good for the fetus. But in those rare, terrifying moments, a maternal code, profound shock, we're forced to make decisions where what we must do to save the mother's life might not be ideal for the fetus. Navigating that ethical and clinical minefield with skill, with knowledge, and with compassion, that is the ultimate test of our specialty. Thank you for joining this explainer.